Boa noite a
Ask,
todos,
the
sejam
Ask
todos
meeting starts on
bem-vindos
Saturday.
ao webinar da Socerj, hoje numa edição especial nas quintas-feiras. Nosso programa de educação médica continuada acontece todas as segundas-feiras às 19 horas e hoje um evento muito especial. Nós temos um convidado especial, o professor Humberto Villacorta, por suas relações já de muito tempo de cooperação, conseguiu aí na sua agenda e vai nos brindar com essa conferência do professor Alan Meisel. Eu passo a palavra ao professor Humberto, agradeço ao professor Alan Meisel e a Humberto a disponibilidade e uma boa conferência a todos. Humberto, por favor.
Boa noite a todos, obrigado, Volney. I'd like to thank Professor Meisel for accepting our invitation. I'm going to say a few words in Portuguese and then I'll get back to you, Alan. Então, como nós temos um convidado internacional e nós não dispomos de tradução simultânea, né? Seria complicado nesse modelo. Então, será um evento em inglês, certo? Eu vou fazer uma breve introdução, não mais do que 5 minutos, depois eu passo a palavra para o nosso convidado internacional e ele vai falar por 20 a 30 minutos e depois a gente abre para as discussões. Eu peço a gentileza dos senhores deixarem os microfones no mudo durante as apresentações e na hora da discussão, quem preferir fazer perguntas diretamente para a Alan Meisel pode abrir seu microfone, mas nós também temos o chat aqui, vocês podem fazer perguntas pelo chat, pode fazer em inglês diretamente, se quiser fazer em português eu traduzo para ele. E eu vou aqui então iniciar a minha apresentação. Alan, I'm going to make a brief introduction and right after me you can share your screen, okay? So, biomarkers do add information to our clinical judgment, no doubt about it. We have plenty of information in the literature showing this. But I'm going to show you one example on how biomarkers can be used. It's not on heart failure as you would expect it. I'm going to move to a different scenario. I'm speaking of atrial fibrillation. And the patient with atrial fibrillation, they have high risk of stroke and also high risk of bleeding because they take anticoagulants. And to assess the risk in patients with AF, the most traditional scores used have been the SHADS-VASc and the HAS-BLED to assess bleeding. And I would like to draw your attention to the variables here because neither of these scores use biomarkers. But let me show you what happens when you add biomarkers to the model. This is the ABC score. ABC stands for age, biomarkers, and clinical history. It was developed to predict the risk of stroke in patients with atrial fibrillation. And as you can see here, 2 biomarkers have been introduced in this score, troponin I and NT-proBNP. They are specific for the heart. And the rationale here is that these biomarkers identify patients with more severe heart disease who are most likely to have a thrombotic event. And in fact, this score using biomarkers performed better than the SHADS-VASc score, regardless of baseline SHADS-VASc risk. You can see here in all SHADS-VASc range, the ABC score reclassified patients regarding the risk of stroke. And they also have this ABC bleeding score. And here again, 2 biomarkers are included, troponin T and GDF-15. And you can see here that GDF-15 was the strongest predictor of bleeding. And again, this score performed better than the HAS-BLED score. Okay, so no doubt that biomarkers are useful, but they also have their drawbacks, their limitations. So this is the ICON-reloaded study published 2 years ago. And you can see here that patients with NT-proBNP below 300 have a very high negative predictive value. almost 98%. That's fantastic. But if you look at the positive predictive value, it's only 51%. So it's good for rolling out the diagnosis of heart failure, but not so good for rolling in, okay? They try to manage this, to solve this problem using different cutoffs for rolling in, 3 different cutoffs according to age, but it's still a big problem. The same happens with BNP. If you have a low BNP below 100, it's okay, you don't have heart failure. If you have high values more than 500, you probably have heart failure. But if you are in between these 2 values, between 100 and 500, the biomarker is not very helpful here. So we call this the gray zone BNP. And this is true also for D-dimer. You're all aware that D-dimer has a high negative predictive value and has been used for rolling out the diagnosis of pulmonary embolism. But if it's high, you don't really care about it because the positive predictive value is low. So here comes the question. Can we use machine learning to improve the accuracy of biomarkers? Can we use machine learning to create better models which include biomarkers and clinical judgment? And to answer this question, to talk about this topic, and it's my honor to invite Professor Alan Maisel. He's an emeritus professor at the University of California in San Diego. And he's been a leader in the field of heart failure and especially in biomarkers. And he's also, in these days, a leader of this group putting together machine learns and biomarkers. Alan, it's your talk. You can go ahead.
Okay. I have my screen okay there?
Not yet.
I think you have to, can you see my screen or no?
No.
Let me see what we had. Share screen. Okay, I think this will be it.
Okay, now we
okay.
can see.
Here we go. Okay, well, thank you very much for Umberto. That was a great introduction and really summarizes, I think, a lot of what I'm going to show in the talk. And thank you for the invitation. Obviously, I would like to be there in person doing this, but here I am in San Diego, and at least we have nice weather, and I can go in the ocean soon. My only disclosure, I founded a little company called Brainstorm Medical to try to be able to utilize products that can help patient care and get other companies interested. So when we test biomarkers in clinical disease, what are we trying to do? You know, ideally, we can use it either to diagnose a condition or to risk stratify a patient or to monitor therapy. Ideally, we would take a condition like acute coronary syndrome or heart failure that has a certain outcome, get a biomarker result to lead to a certain intervention and change that outcome. And that's really what we would like to do. Now, when we talk about biomarkers, you know, old biomarkers have become new and they help personalize treatment. Heart rate's a biomarker and you can titrate certain drugs. LDL is a biomarker for, say, PCSK9. Hemoglobin A1C for the new SGLT2 inhibitors. Potassium, we have drugs for that, QRS, CRT. So sodium, again, we have drugs. These are actually biomarkers. They're blood tests many times, or EKGs, whatever, but they help to manage a patient. But for the biomarkers in cardiology, really, the natriuretic peptides have been the standard diagnostic biomarker for acute heart failure. And so we use that to sort of judge how good other biomarkers are in what they are going after. Now, this goes way back to the breathing not proper days when we found that doctors in the ER weren't really convinced that heart failure was present. There was almost 50-50 indecision. There's a lot of reasons for this. Even the physical exam, the misconceptions on jugular venous pressure, we found that when it was very high, the doctors often mistook it for a carotid impulse. Some doctors tend to think if the JVP is not elevated, it can't be heart failure. And some people don't realize that elevations might only mean right heart failure, not explain something on the left side. So we did back in 2002, a study that we called the Breathing Not Properly study, but it was pretty easy to do, except nobody had any money and no guidance in this, but it basically paved the way for using BNP in clinical practice. It gave us an optimal cut point. The FDA here wanted the rule-out cut point of 100. And as Umberto mentioned, with, I believe, NT-proBNP, the positive predictive value gets between 50 and 75%. So it's not nearly as good as the negative predictive value. And that's going to be very important as we talk about machine learning. But it did tend to clarify the diagnosis, having that BNP. But like other biomarkers, natriuretic peptides have some confounders, and which means that you have to learn how to use it. There's times when you're going to get higher natriuretic peptides than you expect. Sometimes you're going to get lower than you expect, especially in the obese patients. And in the community, when we pick out levels of which we would like to bring asymptomatic or relatively asymptomatic people in to see a cardiologist, we give numbers like this, but they're not that good either. Here you can see that that level of NT-pro of 125 is really that, well, the median value for an 80-year-old is 150. So we're going to get an awful lot of, say, false positives in that situation. And then, of course, we won't settle the argument here, but about which would he use BNP or NT-pro for valsartan, sacubitril valsartan. So that's the BNP. Let's look at their other major biomarker that we use, the troponins, the new high-sensitive troponins. What are we getting into? Because each generation of high-sense troponin, you can see elevations in larger percentages of otherwise normal patients. So what that means is people say, well, they're not a plaque rupture MI, so are they false positives? Well, they're not really false positives when any elevation above the limit of detection has a greater risk. And in fact, the more the troponin is elevated, the greater the risk. In heart failure, we see this is true. From Frank Peacock, the quartiles, troponin elevation, and the in-hospital mortality. And so we know troponin's a marker, not just of myocardial infarction, but myocardial injury. And that injury can lead to, cardiac, it can be from wall stress, from hypertrophy, from kidney failure, arrhythmias, a whole host. And so the guidelines have come out with, above the 99th percentile that you can have a type 1 MI, that is plaque rupture, or a type 2, where you have oxygen supply and demand imbalance, and then other examples with or without myocardial injury. The way we're looking at it, as I'll tell you shortly, is I like to look at it, you're either type 1 or non-type 1, because the type 1 goes to the cath lab. Maybe non-type 1s don't, but it's very hard to separate. Impossible, in fact, without machine learning. And in fact, the more sensitive you give an assay, the less specific it is. So yes, all these rule out, in fact, the FDA has now allowed us to submit rule out applications where it used to only be rule in. But the more we can rule them out at an hour, there's going to be more of these troponins that are reputedly false positives. So what are we going to do? How are we going to improve this accuracy? It's going to be a mess. Well, biomarkers can give you information that you cannot get just from looking at the patient. It can go above and beyond that. But we also know that if you use biomarkers incorrectly, it'll make a bad doctor worse. And if you use them correctly, it'll make a good doctor better. Here's an example. Here's a bad, what do I mean by that? Biomarkers for guiding therapy is secondary to clinical judgment, and you need to take all things into consideration. Here's, if you can read this, from a New York City emergency room, where a doctor saw a patient, was presented a patient with chest pain and didn't see the EKG, just told there was a high troponin, and wrote on the order sheet, cardiology to see for elevated troponin. This is not the way to use biomarkers. And biomarkers, what we want to say, they are not standalone tests. Now let's bring in AI. Total revolution in healthcare. This is going to work well, bringing biomarkers what it needs to have to really be an everyday use for medicine. An example, well, I'll give you a few definitions. Artificial intelligence versus deep learning. Well, sometimes the difference is clear. That's from me, nobody laugh. But other times, artificial intelligence, we loosely mean incorporating some human intelligence into machines. So when a machine completes its task based on some rules to solve problems like algorithms, this intelligence behavior is what we call the artificial intelligence. Some machines can even move or manipulate objects or recognize when someone has raised their hand or solve other problems. Now, machine learning, which is what we like to use, is a method of data analysis that learns from experience, enabling computers to find hidden insights without necessarily be programmed to do so. It'll analyze data and learn to make decisions and predictions. And this can include supervised machine learning, where we feed it the data, and then later on, after it learns a lot, unsupervised learning. So look, let me bring this down to a personal level, why I wanted to get into this, because I knew a lot about bedside cardiology and could understand decisions that younger people, less trained people, didn't really understand. Well, it wasn't that they didn't know the facts, it's just my neural networks, all those years of learning things, they knew how to combine features of a history, a physical exam, and biomarkers so that I can give appropriate weight. It's not just that a biomarker of 99, a BNP, rules out heart failure, because biomarkers are continuous variables and they can be treated as such. So just as I give younger doctors supervised learning, supervised machine learning can give them the benefit of wisdom, well-trained, seasoned doctors. It can help a doctor who's tired, has a large workload, and takes care of very sick patients. So, to give you an example, how much should you weigh at BNP level if you're evaluating a dyspneic patient? Let's say your patient had a BNP of 1,000. Well, that must be heart failure, right? Well, what if they had a history of previous heart failure and now has a fever and pneumonia? That could do it. What if they had a large pulmonary embolism and right heart failure? That could do it. What if they had sepsis plus acute kidney injury? That could do it as well. On the other hand, BNP of 90, it can't be heart failure, can it? Well, obese patients, very low BNPs because of the clearance mechanisms in adipose tissue, that could explain it. Or maybe they had acute hypertensive pulmonary edema where you won't see the BNP elevation till the next day. So biomarkers are great at ruling out, but biomarkers plus AI can rule in. So we can help with a specific diagnostic process, get people diagnosed quicker, move them out of the ER, reduce costs of unnecessary tests, reduce readmission penalties, et cetera. Now, some people say, it's just statistics. They'll give you just the same kind of answers as this hidden secret data. Well, no, it's not true. I'll give you an example, 30-day readmission predictors for heart failure patients, something we're tackling. Well, look at this. These are just a bunch of studies. The C statistic is pretty bad, just you can't do it. And you start using, this is just one study from Harlan Krumholtz, just using a little bit of machine learning, and you can immediately up that to about a 25% increase in receiver operator curve. So let's bring a couple examples. Our first target was to look at high sensitive troponins, because what are we going to do? They indicate of a type 1 MI, but heart injury, we saw the supply demand, and there may be no plaque in the coronary artery at type 2. The new troponin test is so sensitive, you can detect it in half the people. So you might get a lot of people going to the cath lab that's not necessary, So it really has to be quickly distinguished. And we've done this with the troponin I and troponin T now. And through proprietary things, I can't tell you what all these variables are. We took just about 200 variables and we dumped it down through process of machine learning to about 20 variables. And that 20 variables gave us a 95% separation, more accurate than anybody. I'm about I'm about 75, 80%. I'm pretty good. So all these variables you can obtain by the history and by the electronic medical record by the time that first troponin result is ready, or the second. So it can give you this data. We have done this with troponin I, we have done this with troponin T, and we are cross-validating over a number. And it's pretty easy to do. Well, how can you do this? Well, you can have something on your if you want to do it through the EMR, you can plug it. You can plug here. It gives you plug in the data. You get the first troponin, the second troponin, and it gives you the risk by machine learning of a type 1, UC9, and explanation, which would be and what to do, anticoagulation, admitted unit. Well, we got even one better than that, because if you take a minute, we're working with a company to try to bring this so we don't need the electronic medical record, because sometimes things you want to pull down, they haven't been entered. The doctor's too busy with COVID at the bedside or with ACS. So you can put it in and draw this down on iPad. Let me give you an example of let's see if I can get this. Oops. See if I can get this on. Yeah, this will just take a minute or so of something we're working with to try to present. You fill in the iPad and get the things, information you need right off the bat. Let's see. Nope, one more second. I'll see if it works. Yeah, here it is. Okay, let's see. It'll play. Okay, so let's think about it. This is how you can have it right there, and you can enter the key data, and you avoid mistakes from the EMR or data that hasn't gone to the medical record. A couple more cases. Let's look at shortness of breath. This is where biomarkers and machine learning are going to be really, really good partners. We want to make a panel that will have biomarkers, like some of those there, along with some features of the history and physical. And probably machine learning will be able to pick out any one of these kind of things: dissection, pneumonia, pulmonary embolism. And in fact, our group is we think two ones that you haven't figured that you would diagnose in the ER. We're going to try to put in these panels. We already have a lot of patients to work with. That myocarditis, you can get a hint right at the top, and also amyloidosis. A lot of times we forget about them, but they often present. One of the types presents with either arrhythmias or heart failure. So this is something machine learning is going to really be important. And look at this. Here's looking at two biomarkers predicting who's going to get cardiogenic shock in the ER. And these are SC2 and NT-pro. And the survivors are in the white. The people who died are in the gray. And you see the time out there. And ST2 rises very early, very prominently in those that are going to die. And NT-pro does as well, but not as prominent, not quite as early. When you put them together, though, you have, really at about 12 hours, you could know who's going down the hill. This is really important because there's a lot of companies, there's a lot of things we can do, but some of these procedures, devices are extremely expensive. If we know who's going to benefit from these, then I think this is something that will be very, very helpful going forward. And also HFpEF, something that has a lot of mechanisms, and here are some, you can take, you all know these, and also has a lot of comorbidities and has a bunch of biomarkers that are associated, it's just made for working with AI, with machine learning, and these kind of biomarkers and other etiologies. And finally, let's talk a little bit, we have a group called, which Umberto Villacorta is very much a part of, the COVID MLB group. It's not Major League Baseball, it's Machine Learning Biomarker Group. And what we're doing, we have maybe 20 countries all over the world. We're trying to bring to the table the following. I'll just summarize briefly: the diagnosis, what to do with the positive, minimally symptomatic, inpatients, and then outpatients. So we're not where we want to be with diagnosis. There's a lot of false negatives, some false positives. But machine learning, you can clear this up. You can clear up fatal mistakes. For instance, if you have a negative test, but you have, say, machine learning, a COVID exposure, and an IL-6 or high GDF-15, it might make you worry that that's a false negative and you might do something else. So you can find a selection of biomarkers that will be very important here. Now, how about the patient who tests positive but are minimally asymptomatic? And we're seeing that more and more in this second round as we have a younger patient population. Well, most of these aren't admitted, but you know what? Some go on and die. Some go on and get sick. Could we have known in these folks? And some get a random pulmonary embolism. Some develop heart failure. Some get out of hospital cardiac arrest, renal failure. How do we tackle it? Well, what we're hoping to do is to separate with biomarker profiles a high and low risk patient. And we're going to make a machine learning biomarker score. So we're hoping that the high score will say associated with very high risk of going home and admit. A low risk score, you can treat as an outpatient, and then we'll use the other part of machine learning in this gray zone where we think this will be valuable. Inpatients, what we want to know is who's prone to catastrophe and what to do to prevent. Well, if we knew they were going to get kidney failure, we could concentrate on fluid monitoring, hold renal toxic meds, hold contrast material, early renal replacement therapy. Pulmonary embolism, start high dose anticoagulation. Respiratory failure, maybe antifibrotic medications. Myocarditis. Also, who's going to die and who's going to recover. This is important just to sort of prepare family members perhaps a little bit better. So finally, outpatients. Many go home, and as we are finding out, much to our dismay, do not get completely better. Cognitive problems, continued breathing problems, etc. Arrhythmias, heart failure, late stroke, pulmonary embolism. And you know what? Many don't even go home on any drugs. And now we're hearing you could get a second infection possibly. So we're using machine learning and biomarkers to personalize treatment. So we can certainly, many go home, don't get better. We can maybe use machine learning to make sure at least these problem patients get seen earlier and they go to the front of the line. Fibrotic disease continuing in the lung, we could send them home on spironolactone. We have a study where we'll be doing that. Arrhythmias, certain people will deserve ICDs, heart failure, depict the etiology and treatment, late thrombosis, send them home for lifetime anticoagulation. So there's so much every day we're finding. The surge of out-of-hospital cardiac arrest, that could be from pulmonary embolism, could be myocarditis, we don't know. CNN, this is just from the other day in the CNN newsroom, that the cardiovascular complications, almost a quarter of patients, 8 to 12% have acute cardiac injuries. So it's on everybody's, consciousness. And that's why I think this is going to be very important. Now, here's another thing. This is something Dr. Villacorta, this is looking at pulmonary embolism, not in the COVID, but we're going to use this to bring to the COVID. This is from 7,000 patients. We developed BSM as Brainstorm Medical with D-dimer and without D-dimer, looking at the false positive and the true positive ratio compared to a Wells score, which is out here, a PERC score, which is way up here, and a Geneva 2 level score, that using machine learning, we were able to do better at picking out, especially the true positives than any of the other scores. And here's a little bit more probability of D-dimer being negative or D-dimer value. And I can't show this too long because it's not published yet, but basically you can make D-dimer into a beautiful biomarker that is, as you say, if you look here, this is the mean of the negative patients, model of mean negative D-dimer patient, that you have, if you're in the center of this, you have a 99% probability of being negative. And here in the cluster of D-dimer positive patients, you can see that there's only a 5% probability of being PE negative or a much higher positive predictive value. So this is going to be crucial. So as a final warning, look, it's here to stay. It can be a big eater. It takes a lot of data to train it because a vast number of parameters must be estimated. But we're finding out that if you give it good data, solid data, you can get good answers. For our MI algorithms, type 1, type 2, we only needed about 200 adjudicated MIs or not MIs. So we knew what it was to come up with that. Well, who's responsible? You know, they talk about AI-based driverless cars are safer than human drivers, but what a pedestrian death, what does it mean? Who's at fault? Here you're in, when handing radiology or over to artificial intelligence sounds appealing, hey, I'm being sued for a misdiagnosis. What do I do now? Sorry, buddy, comes with the job. Well, the future of AIs, I think, is fantastic. We're going to identify novel genotypes or phenotypes of heterogeneous symptoms like heart failure. We're going to look at novel risk factors and score systems and add them to existing models, like we're doing with the pulmonary embolism. AI can drive improved patient care because physicians can interpret big data in greater depths than ever before. And we can use it to generate hypotheses, perform the analytics, and optimize our applications in clinical practice to really bring on an era of precision medicine. So finally, will AI replace doctors? Everyone wants to know. Probably not. AI doesn't really want to replace doctors. What machine learning and neural learning should do is make doctors better. In fact, in the future, a doctor with the use of AI will make a better doctor than the one without. It's a tool for all of us. And I'll stop there. Thank you very much.
Okay, thank you, Alan. Excellent presentation. Is there any question from the audience? You can either unmute your microphone and ask your question or use the chat. But while people are warming up for a question, let me start.
Yes, first, congratulations, Professor Maisel, excellent lecture. And some time ago, I heard a lecture in a Congress. You have told us that BNP will make the good doctor better. And I would like to ask you that now that you add machine learning and biomarkers will make the good doctor even better. Is this the main idea?
Yeah, yes. I think that I've been working with BNP for 20 years. So I don't know that machine learning will make it better for me. Okay. But because I know how to integrate the level wherever it is with other features. But many younger doctors or very busy doctors haven't had all that experience. In other words, they haven't established their neural networks to synthesize that. And that's why if we have something, for instance, on an iPhone, we're working on a gray zone BNP, 1 to 500 now. We may just find 5 or 6 things you can plug in on your iPhone to tell the doctor what that probably is. So I think, machine learning is for, for areas that you're not perfect at, or you're too busy to really explore every avenue for differential diagnosis.
Alan.
Yes.
You just showed us some data on the pulmonary embolism, and you've created a model which is superior to the 3 other clinical scores. But the important thing is that the machine learning model includes not only clinical variables, but also D-dimer, which is not included in the other clinics. Could you comment on that? And you improve the positive predictive value of D-dimer.
Yeah, I think D-dimer was left out of a lot of the other ones because they couldn't figure out how to really, use it, at least at the top. I think D-dimer is a model for machine learning and what we can do with other biomarkers, whether we make troponin more specific for type 2 or a sicker type 2 patient, or whether we use, it will lead, I think it will lead us to, let's say for COVID, the average, I read recently, people with COVID and pulmonary embolism had a D-dimer of in the thousands and thousands, and sometimes up to 20,000. So machine learning wouldn't necessarily help you there. That's just off the wall. But in fact, what about the person that comes in the ER that is relatively asymptomatic with COVID and wants to go home, not on no meds, and that you find a D-dimer that's one of these gray zone normally, like maybe 500 or 1,000, and you put that in the machine learning and they have a few other things in there and says, this could mean that you are at risk for pulmonary embolism, and they would go home on, rivaroxaban. So this could be, I think this could be very, very helpful. And this is what, as we want to use biomarkers to guide treatment, I think this is, I think pulmonary embolism is one of these that's going to stand out because this is so frequent. Some people say they see up to 20, 30, 40, and even one of the groups said like almost 50%, if they look hard enough, have pulmonary embolism. So going forward, I think the D-dimer is going to be huge, and it's going to spur research into other hematological kind of variables that we can look at.
We have a question from the audience, Dr. Eduardo Câmara. His question is, are you using scores as an input to the machine learning model, or the data is used without previous interpretation?
It's a good question. The only ones we've used scores for so far is the pulmonary embolus. And you can either put the score, we've done it both ways. We put the score in, or we put the variables made to achieve the score. Hopefully we will get the same score. But I think to prove you're better than something, you have to have the model with the score, and then you add the D-dimer, and you put it all in a machine learning, and you come up with the best interpretation. I think going forward, I think we're going to try, if we want to beat a model, you have to have the model, and then you have to redo it with machine learning plus your biomarker that you want. And I think that's how we'll do it. And it probably should beat it every time, but you want to use the same variables that was used in the PERC or or Geneva, whatever. That's very important to do.
Any other question? Meanwhile, let me make a question. Alan, it has nothing to do with AI, but just a curiosity. We wrote a paper 4 years ago, a review paper on ST2.
Yeah.
And at that time, I was pretty confident that ST2 would hit the top, because especially for guide therapy, because it's typically in response to treatment, it has not is not affected by confounding. And can you hear me?
Yeah. Yeah.
Can you hear me? Did you hear my
Yes.
question?
Yeah.
But it didn't happen. I don't see people talking much on ST2.
Yeah. Well, it's a sad little story. It still may come back. I think that this was owned sort of selfishly by one New York Stock Exchange group, and they were waiting for a big buy instead of parceling it out to all these companies, and it never came. And then they had a couple different assays, and they weren't that accurate. And then they finally developed an ELISA, which is just getting approval so you could do it in the lab. And but they lost a lot of their people to help. So it's in flux. I think that it's still a very good marker for a pro-fibrotic state. And I actually believe with our advent of COVID treatment protocols, we think there's a really rapid fibrotic process going on. We have data in our group showing that inhibiting that with even spironolactone, looking at lung scans that are a matter of a week, can show huge differences. So I think we will have a bunch of fibrotic biomarkers, including galectin-3 and ST2 as maybe phenotypes and genotypes for fibrosis, and then we'll follow them. So it could be back, but it just shows you, and I was very favorably disposed toward ST2, but you have to make that happen, you have to have industry support because they can fund the big studies. It's not a pharma company. Often they don't have the money to do this, and this company didn't have the money to do this also.
Okay. Any other question? I have a question here. Are you training the data with classic machine learning models or deep learning models that being used as well? Or being used?
Good question. If you want to be involved, talk to Umberto, because we're starting with supervised training only. And the deep learning may or may not happen. I think if we move ahead with COVID and we get 3 or 4 or 5 more episodes where it comes around, all the things that we learn in machine learning, I think the deep learning will be able to take over. My suggestion to you, if you want to use machine learning and biomarkers for a project, I think the best thing to do is to use just supervised machine learning. You fill in the columns, what it wants to do. So if it's MI or not MI, make sure it's adjudicated. Pulmonary embolism or not pulmonary embolism, heart failure or not heart failure. Put in all the data you can. It likes a lot of data. The best data you can put in is the objective data. So sometimes if you come up with a pretty good result, but half of the good stuff is subjective, like did you feel chest pain or this or that, or how long did you have it? It's sometimes not as good, not reproducible. So objective things are very good if you can do it. And then you just have to adjudicate it, and it's okay to throw out cases where you're not sure at the beginning. Now, when you publish, you have to, normally you keep all the data. But if you're trying to supervise them to come out with something, a computerized program, you want either is for sure an MI, type 1 MI, or it's for sure a type 2 MI. So in our first 200 of those, we found maybe we had 3 people adjudicate, and if a couple of us weren't sure, and we just threw them out for the time being, because it's good data in will lead to good data out. And then you can come back later with your algorithms and test it and see what those would have been, and then report them if you wish. So I think for right now, for where we are in medicine and in biomarkers and in cardiology, supervised machine learning is mostly what you're going to need, which is good news for you young researchers.
Any more questions?
I could pick out a name and ask them a question. Especially I would pick Oraldico Lima Nito. Who's that? Oris? Is that a doctor? Oh, okay. I don't want to get anybody embarrassed. I just was looking at names. Or Michelle Ahmed. Michelle.
Simões, Ricardo Simões, quer fazer alguma pergunta?
Mariana Guedes.
Aproveite, vocês estão como líder de biomarcadores aí, vocês podem fazer qualquer pergunta sobre biomarcadores, pode escrever no chat.
Okay. It's okay. Oh, here's one. Okay, I can read this one. Great, thank you. Okay, this is from Sergio. Hi, Sergio. Thank you for liking the lecture. Is this in the future or is it now? You know, I think that if we get some industry behind us that runs troponins and BMPs, that we can integrate it with that, and if we can make it easy so that doctors don't have to interrupt their workflow to do it, then it could come on very quickly. The little pull down GUI I mentioned, where the cartoon, if we can use, we're negotiating to have that with us, so people can just use that in their day-to-day life to fill in things and get those answers. So it's not going to be. It's going to. I believe it's going to start out with the type 1, type 2s to help us know what's what and which of those type 2s can go home and which can't. And then after that, there's be a lot more. So I mean, it's coming. I think whether people will accept it, maybe not at first, but I think a little more. You know, most BMP it took 10 years and troponin 10 years. But I think we're putting this together and coming out with something that will easily fit in some handheld device that they have. And I think that it should go quicker. Umberto, what do you think?
I think that it's for now. It's not going to take a long time. When you show that we can easily identify patients at risk and you can improve accuracy, I think that people will accept it.
So if also I'll say, if you guys are medical students or residents, and you know, Umberto and I are very involved in machine learning and in heart failure, pulmonary embolism, and in COVID, and I'm sure you could use some help with some of those database pulling that you're going to need to do, Umberto. So
yeah, I already have some students helping us on that.
Maybe one or two really will have resonated from this talk, and we'll see what happens. Okay. AI, yeah.
Oncology.
Yeah. Is helpful in oncology? Yes. We have a group, we have a cardio-oncology group actually. And it sort of fell apart, not because of the COVID, but we have some very good people in our group that are well-known cardio-oncologists. And I think this is going to be a very up and coming, you know, who gets what medicine, especially, you know, deciding, yeah, who we can start a medicine on and not have to worry about cardiac dysfunction coming, or how to monitor cardiac dysfunction, or with these new checkpoint inhibitors, you know, the side effects really are myocarditis. So we have some biomarkers that may help with that as well.
Any other question? One more question. Read that, Alan.
Huh? No, helpful in oncology, future of cardiology, the AI treatment of heart failure.
How do you see the future?
Yeah, well, you know, we've used already, you know, biomarkers, we've used NT Pro to guide care in heart failure, and it works pretty well. You know, I think that gives us a final target to get down to, but it doesn't specifically tell you what drugs to start. So for instance, there may be, you know, if you get these anti-fibrotic markers up, you may want to move more with the anti-fibrotic drugs, you know, and I think that will help. Whether it's HFnAF, HFpEF, or HFrEF, I think the biomarker cohort with machine learning will help you describe them better and maybe follow treatment. Right now, what we're looking at to do with heart failure is two things acutely. Number one, who that is treated in the ER is safe to go home. It's a hard question. It's hard to get data. In the United States, we admit 90%. And my neural networks say we don't need to admit 90%, maybe 70 or so, 60. But we haven't been able to look at that. That's huge. And then the other, what we want to do, and I talked to Berto about this, is of course readmission. How to prevent readmission at the time of discharge. To really have a machine learning group that could look at the the trajectory of the BMP during a mission, look at potassium, look at creatinine, look at breathing, look at chest x-ray findings, a whole host of things. And this could be very important, and it could be done in your handheld device.
We're also working on the gray zone BNP.
Yeah, I think I mentioned that earlier, between 1 and 400 or 1 and 500. It doesn't take many machine learning variables to help. And I think right now our early data is like about near 90% accurate to what our AI guy has. So. Okay, I think they're tired of me. Yeah.
Any more questions? No questions?
Okay.
So, okay.
Okay.
Alan, we are very grateful that you accepted our invitation. It's an honor for me. We've been working together. We know each other for almost 2 decades.
Ooh.
It all started with the BNP 20 years ago. And okay, it's an excellent talk. And again, I'm going to say a few words in Portuguese to the audience. Pessoal, muito obrigado aí por participarem. E eu queria avisar que essa conferência do professor Menzel, ela vai ficar gravada no site da Socerj. Tá? Então, vocês podem rever e podem passar para outras pessoas, divulgar para outras pessoas, se tiverem interesse. Ok? Então, muito boa noite a todos. Alan, thank you once again.
Okay, thank you.
Bye-bye.